Well, good evening, everyone, and welcome to a Canadian Alliance for Rare Disorders of the Skeleton and Canadian XLH Network collaborative webinar. This evening, we're talking about transition of care in XLH. My name is Dr. Leanne Ward. I'm a professor of pediatrics at the University of Ottawa, where I hold a research chair in pediatric bone disorders, and I'm a pediatric endocrinologist at the Children's Hospital of Eastern Ontario. And joining me this evening are members of the Canadian XLH network, as well as guest speakers and moderators and individuals interested in research and clinical care in bone disorders. And it's such an honor and a pleasure to have you all with us this evening. I'm going to just share my slides to orient you to the event tonight. So this is part of the 2024 Triple CBH and CARDS virtual series. Triple CBH is a patient and health professional educational initiative, and CARDS is an opportunity to work directly with the patient advocacy groups for individuals with rare bone disorders across Canada. As I mentioned, we're partnering with the Canadian XLH network this evening, and I just love working with this network. They're so vibrant and dynamic and so willing to share their stories, as you will hear tonight. And of course, sharing stories is an important way that we all learn what the unmet needs are so that we can continue to move the dial on optimizing clinical care. We acknowledge that the land on which we gather is the traditional unceded territory of the Algonquin Anishinaabe people. The Algonquin people have lived on this land since time immemorial, and we're grateful to have the opportunity to be present in this territory. We're talking about transition from pediatric to adult care in XLH this evening. This is a topic that has been specifically chosen by the Canadian XLH network. We know that moving from the pediatric environment where the condition has been diagnosed to the adult milieu can present with certain challenges. And so tonight we're going to hear about the thoughts and experiences of individuals with XLH who have made that transition. Listen to experts as well, comment on the transition process, and together better understand how we can move forward in order to optimize this delicate period of time moving from the pediatric to the adult milieu. In a few moments, you'll hear from Sherry Van Vugt. Sherry is the president and chair of the Canadian XLH network, and she's going to be saying a few opening remarks and also kicking off the webinar by sharing some experiences with the transition of care process as a mom. We're delighted to have other members from the Canadian XLH community sharing their experiences this evening as well. Emmett and Susan Morgante will be speaking about their experiences, and Alice Van Vugt, the daughter of Sherry, will be sharing her thoughts and ideas and experience on her journey as she moved quite recently from the pediatric to the adult milieu. It's a pleasure to introduce Dr. Edward Ted Vassarelli, who is an associate professor in the Division of Orthopedic Surgery at Western University in London, Ontario. He's the head of the arthroplasty unit at London Health Sciences Centre, University Hospital, London, Ontario. And Dr. Vassarelli will be co-chairing this event with me this evening. We're going to hear two dynamic speakers who are going to give keynote addresses on transition to adult care in XLH, and I will introduce them shortly. But the first of the two speakers, or perhaps it's the second because the other speaker will be going first, is Dr. Caitlin Cassidy, who's an associate professor in the Schulich School of Medicine and Dentistry at Western University in London. And I will introduce her more fulsomely in a moment, and she will be co-presenting with Dr. Rachel Reardon as an assistant professor at Schulich School of Medicine and Dentistry, Western University, London, Ontario. So we're very delighted to have both Dr. Cassidy and Dr. Reardon speaking this evening, and can't wait to learn from you and hear about your thoughts on optimizing transition. We certainly want to create an opportunity for everyone to speak and share who would like to. And so the ways that you can participate this evening, you can certainly just sit back and listen and reflect on the conversation quietly, but you can also put a comment or question in the chat button and we'll be moderating that for you. And also you can raise your hand and speak directly to the group this evening. So Dr. Vassarelli and I will be monitoring the chat and the raise hand function to make sure that if you want to have an opportunity to share, that you do so. I'm grateful to the Triple CBH and Cards Steering and Planning Committee, which is made up of rare bone disease experts from across Canada. They have assisted me in planning the portfolio for the webinars and the educational events this year, and I'm grateful for their engagement. The webinar usually goes until 8:15, 8:30 at the most, and at the end of that portion of the evening, there's the opportunity to hang back and just catch up socially with the XLH community. So we call it a little virtual catch up over coffee. So you're welcome to stay, whether you're a speaker or a member of the community or someone who's patched in to take part in this event and get to know the XLH community a little bit better. And so with that, I will stop sharing my slides and I will introduce our first speaker. So as I mentioned, Sherry Van Vugt is a founding member of the Canadian XLH Network. Her daughter Alice was diagnosed with a spontaneous case of XLH in 2008 at the age of 4, and Sherry has been involved in the XLH community since 2011 after attending the first XLH Day in New York State. That must have been exciting. Her focus in leading the Canadian XLH network is ensuring that access to healthcare and new treatments is made available to all Canadian XLH patients. And Sherry lives with her husband and daughter Alice in Kitchener, Ontario. So Sherry, welcome, and thanks for opening the webinar with a few words on behalf of the XLH community.
Thank you for that, Dr. Ward. You guys can hear me? Okay,
yes.
Perfect. So I would love to thank Dr. Ward and Dr. Vassarelli, who are co-chairing this tonight. Without you guys and without cards in the Triple CBH, we would not have access to the resources, to the doctors that you always bring to these events so that we can learn more. We are a very small XLH community here in Canada, and resources are limited. So we reach out to Dr. Ward. Dr. Ward, we give you an idea. You pull people together and just bring in the most incredibly interesting and how would I say this? Interesting doctors and interesting presenters who open up our eyes to the resources that are out there for our community. And we greatly appreciate that. We would not know as much. We would not have access to learn as much without your team, you guys, Sirdar, and the rest of the folks at the Triple CBH and Cards community. So I thank you for that. And I'll look forward to learning from both Rachel and from Caitlin. I'm very excited to hear what they have to say, and I know that the community is as well. We've been kind of chatting behind the scenes, and with that, I think that's it. I'm going to be short and sweet. I'm a little under the weather, so we'll cut it at that. But thank you, as always, for everything you do for our community.
Thank you, Sherry. It's an absolute pleasure to work with you and your community, and so delighted that you're here tonight, despite the little tickle in your throat. Did you want to say a few words about the transition process before I hand it off to Alice, or did you want Alice to take it from here?
So I can say a few words, and part of it will be that once you transition your child from pediatric to adult care, you have to understand that they are no longer a child. And so as a parent who, and my child will agree with this, who's used to being in control and in control of my kids' care, that is all gone away. I am only able to help my adult child so much as they will allow me. I can't just, schedule appointments and take care of everything as I have in the past. And I find that a challenge. I find that really difficult. I find like it's a lot to put on my child. I am a parent of a spontaneous case of XLH. So Alice doesn't have a parent or a family member who has been through the process, so she's kind of winging it on her own and asking for assistance when she can, but I just can't do everything for her in the way that I used to, and some days it breaks my heart because I just can't take care of her as I used to, which I understand is, part of letting your child grow up, but it is very difficult as a parent to see them having to take this on their own. So
Yeah, thanks for sharing that. That notion of letting go, right? And letting go is difficult, I think, with children in any context, but particularly when you have a child who does have a chronic condition that needs to be cared for. So I appreciate the comment that you've made, and that's certainly something we can talk about as we move through this evening. Ted, do you have any comments on anything that Sherry said?
No, well, yeah, no, I certainly appreciate your perspective on that as we get to in our journey with things, as our daughter's nearing that age as well. It'll be interesting and I'm sure a challenging transition for our family as well. And to see how the relationship evolves and partnership changes between parent and child and caregivers, which is part of the reason I'm certainly looking forward to the talk this evening and hear about how we can best facilitate that transition for the kids.
Yeah, thanks, Ted. So that's a great way to kick things off. And we'll now hear from Alice, who is going to speak about what it means to be a young adult who's recently transitioned from the pediatric to the adult milieu. I'll just say a few words about Alice. Alice was diagnosed with XLH at the age of 4. Her family doctor thought that Alice was fine for several years, but her mom had a gut instinct. How often do we hear that? That something was wrong and began advocating for her. Eventually, she was referred to a pediatrician who suspected XLH and was referred to Sick Kids in Toronto, where the diagnosis was confirmed. Alice began treatment with phosphate and remembers how annoying it was to take the medication 5 times a day. In 2015, she joined a clinical trial for a new drug, burosumab, which has helped her considerably. She's active in her local 4-H organization, showing sheep and cows at local fairs, and she's in her 2nd year of undergraduate studies at the University of Guelph. After having had a challenging transition to adult care, Alice would like to share her experiences. So Alice, thank you so much for being with us this evening, and we're delighted to hear about your experience and what was challenging about it and what you would recommend that we try to change in order to make that better for young folks. So Alice, please go ahead.
I'm excited to be here. Can you hear me okay? Awesome. Yeah, so I transitioned to adult care in the middle of COVID, so it might have affected that a little bit as well. But I had my doctors at Sick Kids kept changing, and so communication with them was difficult. What one doctor had planned for me might have been different than what the new doctor had planned for me, and it ended up when I did get referred to adult care, I wasn't exactly told what I would need to be referred there. So having something in place, more resources on how to talk to my doctor would be very useful to figure out, this is what I need to do, this is where I need to go, and what resources I need to do to get there, how to contact the new doctor. It was difficult to communicate between doctors. And even now, being referred to this new doctor at Toronto General, I found that they weren't exactly what we were looking for, and I've had to be referred on to another doctor a second time. So I'm dealing with another transition on top of that, and transitioning from pediatric to adult. It gets kind of dropped on you. I found that it was hard to, it comes really suddenly, and all of a sudden, all of this responsibility is on top of me. Mom helps quite a bit when she can, but all of a sudden, you're the one who's responsible for setting everything up. And I found that difficult, especially if you're starting into like a university degree or something like that. I think you're muted.
You'd think I'd learn after all these years, right? Yeah, one of the challenges of transition, it's a lot of changes all at once. You're off to university, or perhaps you're finishing up your last year at high school with lots going on, and at the same time, you're meeting a whole new care team. As you reflect on your experience, can you think of a couple of things that would have made it easier for you?
I think having more resources on just for me to maybe having a package for me to read through about how the transitioning works, what things I will need to have in place, like how I can schedule things. Also having all of my doctors in one area, similar to like I had it in Sick Kids, with the new with the new doctors in adult care. I have to go to several different doctors for each different thing, different hospitals. When I was in Sick Kids, it was a lot easier where I could get everything done all at once and visit each specialist there.
Yeah, that notion of having a multidisciplinary team that's more in a concentrated area so that you're not navigating so many different hospitals or clinics is certainly a theme that comes out with transition of care, and this notion of having some sort of a passport or checklist or way to keep track of all the different aspects of the care. So you've raised a couple of really good points here tonight, Alice, and hopefully from here, the experience in the adult milieu will be a little bit smoother. It sounds like you've made the transition, and it sounds like you're settling in a little bit now. Great. Ted, any comments? Ted, any comments on anything there that you've heard?
Yeah, Alex, I just wonder if you can share with us how, say, within the pediatric care, you have one point of contact, and now, as you mentioned, you're dealing with a number of different physicians. How do you know who to turn to for advice in certain areas? Do you have a point person who helps coordinate that, or is it up to you to reach out to the physician that you need at any time?
I don't have a person to contact for that, so I'm not always sure. Having something like that would be amazing.
Yeah, sort of a champion, right? Somebody to sort of champion or quarterback the care. That's something we hear a lot in the rare disease space when there's a number of individuals involved. Who is the most responsible physician to lead your care and then assist with the coordination and the communication among the different healthcare providers? So you've hit on a lot of really important themes tonight, Alice. So thanks for sharing that. And I'd like to turn now to Susan Morgante. Susan became involved in the Canadian XLH network during the last year, motivated by her son, Emmett's involvement in the organization and the recognition of the importance of the network in building awareness. Also, Susan wants to support further research and funding for better treatment of the condition. She inherited the condition from her father, then passed the variant gene onto her son Emmett and daughter Madeline, who were both diagnosed as infants. So early detection in your family's case because of the family history. Susan resides in Hamilton, Ontario with her husband and 3 children, and works as a social worker and enjoys reading, yoga, walking, her various animals, including her dogs, cats, fish, and laying hens. My goodness, you've got quite a little farm there at your home, it sounds like. Susan,
That's right.
Great to have you on the webinar this evening. Thank you.
Thank you. So I had 2 children move into the system. So I remember my biggest concern, honestly, with my kids moving to the adult care was the doctor we see is often a 2-hour wait. And I was like, how are my children going to sit and wait for this doctor for 2 hours? Because children aren't patient. And then, of course, the handing over the reins. I don't know if you remember, Emma, a little yellow book that I have over there to give to you, that I wrote all my notes, and I wrote what their phosphate levels were, what all their levels were, and I kept all the papers of their blood work. And I know exactly when Emma had teeth surgery and Madeline had knee surgery. It was all written down. And who's going to look after that book? Because they don't have them yet, so they're not looking after them right now. But who's going to look after that? But so I did attend the first appointment with Emmett. Madeline is the same age as Alice, so she transitioned into adult care during COVID. So that was a phone call. But as we know, Emmett's a bigger advocate than I am of XLH, so he's doing a fine job on his own, and Madeline's doing a fine job too. They seem to transition fine, really. But yeah, I think I would love what Alice talked about, that whole, that we had a physiotherapist for us and a circle of people to help us versus we just go see our doctor, who's lovely, but we just go see our doctor.
So I'm hearing this similar theme to Sherry, whereby that feeling of, having to let go and the perhaps anxiety that comes with letting go and no one to take care of the little yellow book with all the phosphate levels. But it sounds like you feel you really empowered Emmett and Madeline to make the transition. Was there something that you think you might have done to encourage that empowerment, or was that just something that they had inside themselves?
I think with my dad having X-linked hypophosphatemia, and then my mom had type 1 diabetes, the medical system was just part of us. So it wasn't scary to me. It was just something they had to do, right? I did it and they did it, right? And I knew it, where Sherry didn't know it, right? Like I knew the system. Yeah. And when I transitioned, I was put into hospital for 3 days and they made sure I had X-linked hypophosphatemia. Whole different system when I transitioned. Maybe 5 days, I can't remember. Yeah.
No, that's interesting. The concept of learning how to navigate the system, right? And what you're speaking to is with multiple generations of XLH, that this was kind of part of your family's narrative, that that people were engaging with the healthcare system. And I'm sure you do learn and pass on different ways to navigate the system, and very different when someone has the condition and it's not in the family and there isn't that history of having to advocate and understand the condition on the background of the medical system. So that's a very interesting perspective. Thanks for sharing that. Ted?
No, it's you do raise a very interesting point. I apologize about the barking dogs background too, but because the healthcare system, there are times that you really do have to advocate strongly for yourself and your family, and learning where to turn when and what information to communicate is certainly can be challenging for sure.
Yeah, and I've heard people say, the best way to empower an individual with rare disease navigating the system is to teach them how to do that. And then I've heard other people say, well, that's really exhausting. It's exhausting as a patient to have to navigate the system and bear the brunt of that and shoulder that. So there's sort of two aspects to that aspect. So thank you for bringing that forward. And you've already mentioned your son, Emmett. So Emmett Morgante studied human kinetics at the University of Guelph. His end goal is to become a professor researching exercise physiology and biomechanics of bone diseases, ideally specializing in XLH. Because of the family history, Emmett was diagnosed as an infant through blood tests, as we heard, along with his younger sister. His brother got lucky and didn't inherit the gene variant. Immediately following diagnosis, Emmett began conventional therapy, switching between sodium phosphate and phosphate pills, depending on what was accessible and least expensive. And thankfully, Emmett gained access to burosumab through compassionate release. So Emmett, really great to have another young person on the call to speak about the transition of care experience for you.
Yeah, thanks for having me. So I'm 24 years old now, so I've been transitioned for a few years into adult care, but I'd like to say that it's still kind of a constant process of learning. You're always learning how, one of the biggest aspects of transitioning to adult care, I think that's a challenge, is learning, as we've mentioned previously, is learning how to be your own biggest self-advocate, advocating for your own health and understanding that asking questions and sometimes having to pester doctors to get certain things and get answers is what you need to do. be able to be as successful as possible. So luckily my transition was fairly smooth. I saw my pediatric doctor at McMaster Children's Hospital, and my adult doctor, who my mom also went to, so I was somewhat familiar with her from that, also had an office in McMaster. So it was familiar with the hospital, didn't have to go to a brand new location, which I do think made things a little bit easier because it was somewhere I was familiar with. And my mom did take me to my first appointment to help me get to know the doctor and learn things. So it was very helpful. I think that the transition should really start before you just turn 18 and then all of a sudden your transition, which you're not really told about, of course. Like you should be learning how to be that advocate and how to kind of start leading your appointments before you're all of a sudden by yourself. And it also, just because you've transitioned and become 18 while your parents can't take that lead anymore, it doesn't mean that they can't be involved if they're willing to be and to help you. So I think those are kind of the two biggest things I could recommend. And also just keeping notes and keeping track of your appointments is a big challenge still for me. I think as soon as you hear an appointment date, put it in your calendar, get it booked down, and any notes you have during the appointment, try and take notes and try and also have the doctor's notes sent to you as well. You can keep track of your own health. Oh, is it?
I did it again. It's great to hear that you had a fairly smooth transition process, and it sounds like, as you said, everything being at McMaster in one place and the familiarity because of your mom, as well as just the institution being the same, was an asset for you. So that's great to hear, and speaks to the importance of the logistics, right? Just that simple thing like, where am I in this new hospital, right? How can I, how do I get around, and how can I make that easier for myself, and what can we do to make that sort of thing easier? You said something very interesting to me, and I was thinking about this when I was listening to Alice about the fact that you need to start thinking about transition before 18 and probably well before. What age do you think you would think is optimal to start hearing about transition from your care team? If when you look back on your teenage years, would it be 14? Would that be too early? 15, 16?
Yeah, I do think that probably, it's hard to say, obviously. I think probably around 16 is 15 to 16 is probably a good age to where you can really start being mature and start taking the lead in your own appointments and start hearing about what it takes to actually transition and to be able to organize your own appointments is probably a good age, because I don't know if I myself before that would have taken it seriously and actually understood what it means.
Yeah, so warming up to the transition a few years in advance and having the opportunity to take more and increasing ownership over that process of managing your own health, it sounds like would have been something you recommend.
Mhm.
Alice, what age do you think you would have liked to have started to hear about transition?
I
Is
agree
it?
with Emmett. 15 or 16 seems like it would be a good age to start getting those ideas and learn about that.
What are your thoughts?
Yeah, I'd be curious to hear both Alice and Emmett, your thoughts on as a child you often have your parents speak on your behalf, or sharing your concerns or questions with your parents, and as you go through adolescence you start to ask those questions directly with the physician yourself. So I just wonder if you can share some thoughts on how that was for you, and how that changes your relationship with your care providers.
I think that especially starting that when you're younger is useful, or when you're still at the pediatric doctor is good, because it's a doctor hopefully you've been, I know some people do switch around, but hopefully that you've been seen before and that you're already comfortable with. So starting that when you're young with a doctor you're comfortable with, I think is useful. And it can be hard to know what questions to ask, which is why I think starting early is good, because then it takes practice to actually know what questions to ask.
Yeah, learning to ask questions and listen and build on that at the next appointment. I like what you said there about it it takes time to develop those skills, right? Alice, do you have any thoughts on that?
Yeah, I agree with what Emmett says. I also think it takes time to get confident talking to a doctor who's sometimes in a position of power. It can be kind of intimidating to kind of bring things up if you're not 100% sure, and if you're questioning things, it'll be important, but it can be difficult. So yeah, starting with a doctor that you're more comfortable with, like the pediatric doctor, I think is a great idea.
Great. Super. Well, this has been a really great introduction to the notion of transition of care, and you've put some very positive and also some challenging experiences on the table for us to think about. So I'd like to now introduce our keynote speakers, and they're going to give us their thoughts on transition of care in this setting, as well as in general, from the pediatric to the adult milieu. Rachel Reardon completed a Bachelor of Science degree in biology at McGill University in 2006. She subsequently completed her undergrad degree in medicine at Western University in 2010 and residency training in physical medicine and rehabilitation at the University of Ottawa in 2015. She's currently an assistant professor, as I said earlier, in the Department of Physical Medicine and Rehabilitation at Western University. And she's a consultant physiatrist in the musculoskeletal rehabilitation and transitional and lifelong care, TLC. I love that, programs at Parkwood Institute. And Dr. Reardon is co-presenting this evening with Dr. Caitlin Cassidy. Dr. Cassidy is a physiatrist as well at Parkwood Institute and an associate professor in the departments of physical medicine and rehabilitation and pediatrics. And her primary clinical and research roles revolve around the transitional and lifelong care TLC program at Parkwood Institute. Dr. Cassidy acts as the discipline lead for musculoskeletal medicine in undergraduate medical education at Schulich School of Medicine and Dentistry at Western University. So really great to have two wonderful physiatrists, these experts in musculoskeletal health or rehabilitation medicine. And we were quite strategic about inviting you, Rachel and Caitlin, because one of the things that I think a lot about is that, yes, hypophosphatemia and the endocrine aspects of XLH are important, of course, but so are the mobility and pain and MSK aspects of the condition. And so we are so happy to have you with a background in physiatry talking about the transition process, because I think it's very relevant to the physiatry setting. So thank you.
Thank you for having us, and thank you for the introduction. It was very interesting to hear the perspectives that have already been shared. I think we'll touch on some of those things in our brief notes, and I'm sure hopefully have some more opportunity for discussion afterwards. And I think Rachel's going to start us off. But I'm advancing the slides for her, so if I do it wrong, I apologize.
Yeah, we'll coordinate here. Thanks, Leanne, so much for the nice welcome. It's great to be here with everybody tonight. So Dr. Cassidy and I both work in the TLC program here at Parkwood, where we work with a number of adults with various childhood onset conditions, and we sort of assume care for many people at this stage of transition. So we're going to talk about transition in general and how it might pertain to the XLH population. So XLH in adults. Historically, XLH has really been thought about, studied, and taught more so in the pediatric than adult setting. This probably is because standard clinical practice previously was to discontinue conventional treatment once skeletal growth was completed, with therapy restarted in adulthood if there were symptoms. But as you all know, XLH really is not just a pediatric issue. So this graphic is meant to display the spectrum of issues in individuals with XLH across the lifespan. Adult issues really are a combination of challenges that are accumulated during the pediatric years, as well as new manifestations that develop over time and that can emerge in adulthood. And you can see that many of the conditions in individuals with XLH can lead to pain and mobility and functional limitations across the lifespan. Thankfully, XLH has been a moving target, and we're really unsure exactly what the future is with now that disease-modifying therapy, burosumab, is in regular use. We know that burosumab reduces accumulation of bony defects and other complications when used in childhood. In the adult population, it also seems to directly impact some symptoms in adulthood. So in a study of adults, treatment with burosumab resulted in reduced stiffness on the WOMAC scale, which is the Western Ontario and McMaster University's Osteoarthritis Index. And it also increased rates of fracture healing. And this study showed that there was a possible pain benefit as well in adults with XLH treated with burosumab. So the management of individuals with XLH really is best achieved through a multidisciplinary team. And this is due to the multi-system nature of the condition, and because the management can include therapies through allied health providers, pharmacologic treatments, and sometimes surgical intervention. This chart highlights some, but not all, of the team members who might be involved in the care of adult patients with XLH, as well as the variety of therapeutic interventions that might be offered to adults with XLH. Dr. Cassidy and I are physiatrists, or physical medicine and rehab specialists, so PM&R. We are medical doctors who work with people who have functional impairments related to a variety of causes. However, we have particular expertise in conditions of the musculoskeletal and neurologic systems. This discussion is meant to ask, how do individuals with XLH move or transition from pediatric to adult care? Transition of care in general to adulthood is a growing area of research and policy focus across many childhood conditions, and things like juvenile diabetes, cerebral palsy, and the others listed here are just a few of these conditions where transition is being discussed and researched.
Okay, so that was meant to be just sort of like our quick intro of stuff you mostly probably already know. That's about sort of like, why are we interested in figuring this out? This is not just a pediatric condition, that's the whole point. And so there has to be some discussion about how to move people with this condition from pediatric to adult care, but also how best to care for them once they get there. And so having sort of laid that context down, I thought I'd go back even further in history just to show you how big of a deal this has been for such a long time. So this goes, 1989 was the first time that this really starts appearing in a major way in the literature, that in the United States, the Surgeon General had this conference that was called Growing Up and Getting Medical Care, Youth with Special Healthcare Needs. So this sort of sets the stage that all the way back to 1989, people were thinking in a pretty organized way about the fact that we needed to do something to help people with childhood onset conditions move from pediatric to adult care. 1989, 2024, we're still having the same conversations and trying to figure this out. It's not an easy problem to solve for a bunch of different reasons that we'll talk about a little bit. And just to point out sort of from a definition standpoint, really what we're talking about is people who have what we call special healthcare needs. So the definition of special healthcare needs kind of differs depending on where you look, but really it's any patient population who has different needs that in a physical, developmental, behavioral, or emotional sphere that might predispose them to have increased needs across sort of systemic platforms like the medical platform or social services platform across their lifespan. So then this led to some debate about what transition actually really means. So I thought I would lay that out here because I think this is an important concept. So transition is really actually has like a discrete medical definition. And the idea is that transition is a purposeful and planned movement of adolescents with chronic medical conditions from child-centered to adult-centered healthcare. And that is much more sort of wholesome and fulsome, I guess, and holistic. It's like a way bigger deal than just thinking about this as a transfer. So this is not a simple shift of responsibility from a pediatric provider to an adult provider. This is meant to be sort of like a whole life stage that encompasses conversations that begin early, to your points, and continue on after the transfer as well. So what makes this so difficult? There's a lot of literature out there about why transition is hard. And so we could talk about this for a long time, but I thought I would just pick out some of the ones that seem sort of most relevant. So one of the things that comes up repeatedly is that the eligibility criteria for adult programs and the availability of knowledgeable adult providers is a challenge. So a lot of adult providers are not trained specifically in managing conditions that have traditionally been thought of as childhood conditions. So you won't find a lot of people on the adult side who have spent a lot of time thinking about XLH because they're like, oh no, I didn't do pediatrics. The peds folks learned about XLH. And so, you know, adult providers might say things like, this wasn't in my job description. I thought I would only be taking care of diabetes, or there's a lack of clinical guidelines about how we should take care of people on the adult side of a transition. And disclaimer, the parts that I'm talking about here are not XLH specific. This is across different populations. So, you know, there aren't really a clear set of guidelines for how we should take care of adults after they've made the transition in many conditions. Adult providers often also kind of are frustrated with a lack of suggestions being received directly from their pediatric colleagues about what they should do. So recognizing that the adults often don't feel like they actually have the expertise in these pediatric conditions, they also say, like, it'd be really nice if we could get sort of like, you know, a one-pager from our pediatric colleagues that says, here's what the condition is, here's what you should look for, here's how often you should monitor, et cetera, et cetera. There are also just differences between pediatric and adult services. And so this came up a little bit already. So, you know, the pediatric healthcare system has really focused a lot on trying to make themselves more family-centered. We want to include the family unit as part of the care plan because that actually leads to better outcomes, especially when we're taking care of little kids. That doesn't necessarily translate well if we don't do a purposeful job of transition when we get to the adult side, and all of a sudden you have an adult who has a childhood onset condition whose parent has always been sort of integral to their care planning, and now all of a sudden you get to the adult side and they're like, oh, you know, your parent is no longer involved here. And hopefully it's not that cut and dry, but sometimes it can feel that cut and dry, I'm sure. Many people also talk about a lack of service coordination. So those multidisciplinary clinics for most conditions are way more common on the pediatric side than they are on the adult side. And those multi-D clinics are such an important sort of central place to call. So like if I have a question and I don't know who I should ask, I'm just going to call the XLH team, and someone on the XLH team is going to know the answer. And if there isn't sort of that multidisciplinary program on the adult side and you just have 7 different providers, you're not sure who you're supposed to call. Insufficient insurance coverage comes up a lot in the literature, and a lot of people tend to kind of brush that aside and say this is an American problem. And that's kind of true, but not entirely true. So certainly, you know, adults in Canada can see medical providers, but not every adult in Canada has equal access to sort of allied health services. For example, physiotherapy is not a funded service for a lot of people, or at least not for a long time. In general, there's not enough services to go around. This is especially true once you leave peds. So I work on both sides of the divide. So on the pediatric side, I often hear my pediatric colleagues talk about how there's not enough sort of supports for their pediatric patients. They're right, but they are not maybe always aware of how much more true that is on the adult side. So on the adult side, we have even less access to allied health, for example, than the pediatric programs do. Often there's discussion about a fear of leaving the supportive, familiar pediatric team, and that it's hard to go to the unknown adult team / center. And so that, I think, can be felt by people living with the condition. It can be felt by family members of people living with the condition. It can even be felt by pediatricians who might say, like, it's kind of hard to let go. And if it's kind of hard to let go, that might also speak to it being hard to start thinking about preparing early for transition. You're kind of thinking, I'm going to take care of this person forever. We've done a really good job together. We're going to stick this out. But then ultimately, you know, in Ontario, we have a pretty mandated transfer of care at age 18. And so even if it's hard to let go, we have to start preparing to let go. This is like not at all to scale, but my point here is just considering when you have a rare disease and you go into the adult system, especially, that sort of differences in resource sizes really starts to make a big deal. So when you're on the pediatric side and there's not a lot of resources to go around, but there's not as many people with as many health problems, then you get a bigger piece of that pie. And when you are part of a rare disease group in the adult system where there are a lot of people who have a lot of different healthcare needs, that pie just gets smaller and smaller. And so the slice that can be taken out for people with rare conditions becomes a little bit harder to come by. Okay, so that was a bunch of barriers. What should we do about all of that? What should transition in fact look like? There's a lot of people who have a lot of ideas about what transition should look like. I thought I would go with an actual accepted pediatric statement made in Canada. So the Canadian Pediatric Society has a whole position statement about what transition should look like. So like we said, transition is a life phase that includes moving to the adult healthcare system. It is not just movement to the adult healthcare system. They talk about the importance of developmentally appropriate care being available before and after, and that integration after transfer needs to be part of that plan. The goal is that healthcare is delivered before and throughout the transfer that is uninterrupted, coordinated, developmentally appropriate, and psychologically sound. So these all sound really great. They have a lot more sort of specific points about that, but I do want to go on to sort of a practical model of this that's been created. So this is actually American, but the pieces kind of hold true when you look across Canadian literature as well. So this is from a website that anyone can access. It's gottransition.org. And this is an American federally funded program that's looking at transition to adult care. And they've created a bunch of resources to try to address these issues. So they've created this system that they call the 6 core elements of transition to adult care. And I'm going to show them to you here. And then when I'm done, Rachel is going to take us through how we might actually apply that specifically across the XLH population. So the first thing that you'll see is that discussion of transition policy should begin early. So here they actually recommend age 12 to 14. And that's important to get us thinking about this early. It's not actually saying that kids should start sort of taking control of their care that early. It's just important that we should start discussing the fact that transition will happen at that early age so that we can kind of set the stage and start preparing. And then age 14 to 18, what they suggest is that we start tracking progress. And there's a couple of different ways that we can try to do that. There are different tools that we can start to use to see how prepared people are to eventually make that transition, because that will allow us then between age 14 and 18 also to assess those skills. That's step 3. So if we can track which skills people are picking up as they're aging and which skills they are not picking up, then we can start to see where we might be able to intervene to help make transition a smoother process. Around those same ages, so again, 14 to 18, we should be working on developing a healthcare transition plan, which would include a medical summary. And then 18 to 21 is when we actually make the transfer and make sure that integration into adult practice happens. So there's a lot of literature about people thinking a transfer has been made just because a referral has been made, and then people never showing up to their adult appointment. So that's not an actual transition. That was a transfer that failed. And so we want to make sure that from the back end, that's actually taking place. And then age 18 to 26 is when that really kind of is hammered home, where we want to confirm that the transfer has been completed and that transition has been successful. So these are kind of the 6 core elements of what we think we should be doing for transition. Does this work? Is the next important question. So if we do all of this stuff, is transition better than if we don't do any of that stuff? We have very little literature about this, actually. So this is just one study that I pulled out where they reviewed 700 studies about transition to adult care across a variety of patient populations. Only 25 of those 700 actually looked at whether or not transition with a planned process had any kind of a positive outcome. So most of the papers that are published about transition are focused on sort of what it should look like and what we think it should include and all this stuff, but not a lot about sort of the success of how it works. So these looked at a variety of different conditions that are listed there. So like diabetes, organ transplant, sickle cell condition. And they looked at a variety of different transition programs. Not all of them used this 6 core element plan. Some of them just instituted a single person who acted as a transition coordinator. Some of them instituted what they called overlap clinics, where a pediatric provider and an adult provider were both present in the same appointment. Some just had a transition education center. But here's the real important take-home piece about this, is that it didn't matter what they did. As long as they did something, transition was better. That any outcome that they looked at was somewhat better than it was without any intervention. So the kind of take-home point here is that if we try this in any way, it will be better than if we don't try anything at all. Okay, so we're going to think about how we can apply this in XLH specifically then, and I think I'm going to turn it back over to Rachel.
So as you already know, XLH causes multi-system issues that can lead to lifelong musculoskeletal and functional consequences. It's very much not just a pediatric condition, although with early treatment, we're hopeful that complications and morbidity and functional impairments will be reduced with early treatment. Like any other young person with a chronic condition, adolescents with XLH would benefit from a planned transition to adult services, not just an ad hoc one. And the goals of care across the years shift slightly, but always overlap. So this needs to be kept in mind at all stages. And this just demonstrates how there are overlapping goals in the different stages of life. So pediatric stage versus adolescent versus adult. Rare diseases really do necessitate unique solutions. It's challenging to apply a transition model to anyone, but especially a challenge when a person has a rare condition due to lack of expertise. And so this brings up the very key point that patients need to develop their own expertise about their condition and develop their self-advocacy skills to ensure they receive the appropriate care. So I'm going to take you now back to this framework and try to apply it to XLH specifically. Even if you or your child, for example, is past the point of transition, so they've already transitioned into adulthood and adult care, some of these principles can still be applied. So number one, discussing the transition policy. This is just a reminder that this has to be started early. So this tool suggests that you should start discussing what transition will look like and when it will happen with your pediatric care provider as early as age 12 to 14. So just starting those discussions. So in those preteen and adolescent years. And then as individuals progress through adolescence, that's when we start to assess their transition readiness skills. So it's important to start evaluating one's own transition readiness by assessing one's ability to manage or quarterback their own medical care. You can see here there's a few different tools that are listed, the StarX, On Track, and My Transition app, and you can access each of those by scanning the QR codes below. So these are just 3 different tools that are available online, and the third one is an app that are meant to help evaluate a person's transition readiness and provide resources on that. This is the first of about 3 pages of the StarX questionnaire. So you can see that it asks questions that assess a person's transition readiness, such as how often did you take your medicine on your own? How often did you make your own appointments? How often did you make an effort to understand what your doctor told you? So these help assess how you're doing, but also identify things that you need to work on, or things that you can work on either with your parents or your pediatric care provider in preparation for the transition. This is On Track, which is an initiative through BC Children's Hospital. The goal of this initiative is to support youth with chronic health conditions and/or disabilities as they transition from pediatric to healthcare services. So this is a website that has a lot of resources about transition. And it also includes quizzes that can be used as tools to assess transition readiness. If you click on the Youth Toolkit section, there's a ton of different resources, but this is an example of questions a person can ask themselves to ensure that they are really essentially an expert on their condition. So moving on through the framework into the actual transition planning part. So this is where it's really important for individuals with rare disease, individuals here specifically with XLH, to learn to self-advocate by knowing the basics about their condition, and especially what to expect with their condition in adulthood. A person, for example, can learn about their condition from their pediatric care provider before they leave pediatric care, or they can also access online resources about their condition. And here we've included, for example, the Canadian XLH Network website. It's also really important, if possible, that adolescents and their families collect a medical summary to bring with them to their adult healthcare providers. Working in a transitional program, it's often frustrating when you don't have access to any prior documentation or summaries of individuals' medical conditions. And so if patients sort of take ownership of their own condition and collect a medical summary and bring it with them, that can really facilitate that transition process and fill in gaps that might be missing. In an ideal world, it works really well if the a person can meet with the adult care team prior to discharge from the pediatric care team. I think this is the ideal process, but doesn't always happen. And then when you're meeting with your new adult care team, it's important to bring things like your medication list, health history questions, and any information that has been provided to you by your pediatric team about recommended follow-up. This is just to kind of remind you and emphasize that multidisciplinary team is really essential in management of individuals with XLH. In an ideal adult world, all of these providers would be in one location, as we heard earlier. The other thing to consider is that because XLH has historically really been within the realm of pediatrics, there won't always be an XLH adult team, depending on where you reside. And that's why it's important to sort of be an expert in your own condition. And also just to work with providers who maybe aren't necessarily experts, but who are willing to listen and learn. So I think, you know, in the case of Dr. Cassidy and I, although we aren't experts in XLH, we are experts in musculoskeletal conditions, and so are interested and willing to learn. And I think those are the sorts of individuals that are helpful in forming your adult care team. Yeah, so just to summarize, as you know, XLH is a lifelong condition. You already know that, despite it in the medical community and literature having more focus in the pediatric realm. It definitely has manifestations in adulthood that require attention, and ideally adult care should flow seamlessly from pediatrics and be multidisciplinary. Transitional care is very complex, and even more so when it's a rare disease that we're talking about. And really, it's recognized that we need to consider transition in a dedicated fashion. It's not adequate to simply transfer care to the adult world abruptly. As Caitlin had discussed, there are lots of barriers about transition, as well as lots of proposed models. But and although there's not a lot of research about what specifically works in terms of the type of transition model, we know that doing something is certainly better than doing nothing. And as the person with the rare disease or the condition, there's really a lot that you can do to prepare yourself and advocate for yourself as you're approaching that transition phase in your life.
The end of our prepared slides, but we're excited to chat.
That was phenomenal. That was really great. I loved so much taking notes here as you were speaking. And, you know, first of all, I could really see the time and the effort that you put in to this presentation tonight to give us an overview, but also make it XLH specific. So thank you for that. I really loved what you said at the end, that, you know, that not everybody necessarily is an expert when they come to the care of patients with rare disease, but they do bring their expertise nevertheless. And we know that in the rare disease space, we do need physicians who are willing to learn and willing to advocate and set things up for patients, and in so doing, become experts in the disease. So thank you for being willing to bring your physiatry expertise to this space. I also loved how you walked us through the GOT transition paradigm. And I wanted to understand from the XLH community how you feel about talking about transition as early as 12 to 14 years of age, where the physician, the pediatrician at that time would say, look, this is our policy. Our institution will be looking to discharge you when you're 18. And then at the other end of the bookends, if you will, once transition has happened, to have a mechanism to confirm that the transition was successful, right? So not just sending the patients on their way and not hearing back, but having a mechanism whereby the patients can say, this worked, and the receiving physician can say this worked, and learning from that. So you just had a really wealth of things to share with us, and those are some of the things that I really enjoyed hearing about this evening. So thank you both. Ted, do you have any comments before we open it up to the community and hear what their reflections were on these keynote addresses tonight?
No, I'd echo your comments and thank both of you for the time and effort you put into that. And I do think it's very interesting. You know, there's several themes that you can pull from the evening in terms of I think concerns from families and patients and care providers, and I think it's important to have a dialogue to see how you know, we can work together to improve things for each stakeholder, because I think at the end of the day, everyone's wanting to achieve the same goal, and it's a matter of what tools and education and processes can we put in place to make sure that we accomplish the best outcome for everyone involved.
Yeah, well said, Ted. Thank you. Good. So community, what are your thoughts on what you heard this evening from Dr. Reardon and Dr. Cassidy? And you've got them here to ask them any questions as well. Some of you are from the London area and maybe, you know, meeting these two wonderful physiatrists for the first time. So it's your opportunity to build that connection.
My first question is, how do we get our patients referred to these ladies?
What a great question. So we're just in the very early stages of looking at sort of how we can support the XLH community, and nothing's kind of fully hashed out yet. But hopefully that'll be kind of coming down the pipeline as we kind of establish a connection with adult endocrinology and adult nephrology, as we try to make this sort of multidisciplinary and kind of best created to meet needs. So I guess more news at 11 is the answer to that, because this is very early in terms of our discussions with the group about sort of how that might work.
Great, thank you. Thank you for everything. It was amazing what you two just shared with us.
Oh, thank you.
And Sherry, I can tell you that we had a lovely meeting recently with Caitlin and Rachel, as well as other physicians, nephrology, endocrinology, pediatric and adult, in the XLH arena, and there was just a ton of excitement in the room and lots of ideas about how to pull this together. And so I can tell you that in London, there's a lot of interest and effort that's going into shoring things up. So as Caitlin said, more news at 11.
Amazing, amazing. Thank you, everyone. Thank you.
Josie.
I was just wondering if there's anything that like the Canadian XLH network or XLH patients can do to kind of support you along that journey of like creating a potential XLH kind of clinic.
What a great question. I don't know if I know the answer to that yet. I probably Leanne and Ted might have more ideas about that than I do. I think right now we're just trying to figure out sort of like really basic logistics about like where would it be and how often might this take place and who would attend. I'm sure that there are probably opportunities to support that. I just don't know if I know yet what they are. I don't know if Leanne or Rachel or Ted, if you have any ideas about what those could be.
I mean, as you were speaking, there were a few things that came to my mind in terms of synergy between you folks and the Canadian XLH Network. And so Canadian XLH Network, on your website, do you have a transition of care toolkit? Or if not, would you like to develop one? Because we could work with you and with Caitlin and Rachel, to think about developing one, something that can be posted on your website that goes through sort of the checklist that the pediatric family moving to the adult family needs to think about. Does anybody from the community want to tell me about your website and whether you have anything along those lines already about transition, or if that's something you'd like to explore with us?
I don't think we have anything on there, but Spencer is our expert to the website, but I don't believe we have anything of our own on our website for that. We were just back and forth, Alice and I, saying we need to get those apps up on our website for kids to start learning how to transition, but having our own kit would be terrific, would be helpful. But I think Spencer's on here, is he not? I think Spencer's here tonight.
He was, and then I think he's popped off.
Okay, that's too bad. That's a shame.
I don't think we have them on the website, and I know Alice and I had them in our little mini event we had, but we didn't post them anywhere. Like, it was just a slideshow that we shared with the people that were at the event. So
right.
Mm-hmm.
Caitlin and Rachel, do you have a checklist or a tool? I mean, there's certainly things in the literature, right? And there's actually been one that's been prepared specifically for XLH that I'm aware of. But do you have any tools that you use for families for transition?
I'm mostly seeing patients on the adult side. So like once they've come to us, Caitlin, in your when you see your pediatric patients, are you using a tool regularly?
I would say not regularly. I think we talk about them in specific situations. I think the ideal situation is that we would talk about it with every patient. Our challenge, most of the patients that we see in the transitional lifelong care program have some pretty significant disability, often with cerebral palsy or spina bifida and other conditions like that. And often we spend a lot of our time talking about sort of like pressing medical issues that often kind of doesn't leave a lot of airspace to have some of these or other conversations about, you know, like maybe softer skills is probably not the way to describe them, but is maybe the best term I can come up with off the top of my head. There have been initiatives in other places where they've had actual, what they call transition clinics, where it was like, you're going to come to this appointment. We're not going to talk about anything related to your medications. We're going to talk about, like, do you know what the disease name is? Do you know what that means? Do you know what parts of your body it affects? Do you know what your medications are? Have you ever called the doctor by yourself? There's pros and cons to that. Obviously, some of that doesn't need to happen in a medical appointment is probably one of the biggest cons to that, because the system doesn't have a lot of resources to probably support those extra in-person appointments, especially when there are great tools available already online. So I think that there's probably a good way to leverage those to be done a little bit more sort of on your own, recognizing that, you know, I think, Leanne, you made a great point about how exhausting it is to be sort of your own advocate and expert all the time. But the reality and the truth of the situation is that it's probably something that we can't avoid for you entirely, nor can you avoid it for yourselves. And so I think that it's probably something that is going to take a little time investment for each person if they want to make sure that they have that sort of confidence and full knowledge base going in to the adult side, where maybe you're not sure yet that the adult provider has all that information or has all of that knowledge base themselves. And so I think it would be great probably to have something on the website where people could look at generic tools, but then also be able to look at, you know, maybe a way for you to make your own yellow notebook, right? Of sort of what are the key pieces that I need to have written down as I go into my next appointments. There used to be a really cool tool on the Sick Kids website called the My Health Passport that they have unfortunately sunsetted. So it was like this website where they had like a drop down menu, and it had like, I don't know specifically if it had XLH. I never thought to look for it before they closed the program, but it was like a drop down menu of like every condition under the sun, and you would click on it, and then it opened up this thing, and it had like all these spots for you to write down things that were specific to your condition, and then you could print it out on this tiny little card that you could carry in your wallet. And then they were like, well, this maybe isn't relevant to people with like phones and stuff anymore. So I think that's part of why they decided not to have it anymore, but the concept is still good. And so if you had just sort of like a worksheet that could be created that could go onto the network's website of, you know, maybe take a little bit of time and get these basic bits of information about your health that you can take with you, not only when you go to your appointment, but like, what if you show up in the emergency room one day and it's important for someone to know that you've had this, and this happen. So whether that's something that you could store on your phone, or if it's something that you could just have easy, quick access to, I think those are still really relevant tools.
Caitlin, you raise a really interesting point. It's something that I've been thinking about in life. I think we need more manuals around some critical roles. And one of them is like how to be a parent. Isn't it amazing that we have this phenomenal
Oh, yes.
responsibility and there's no manual? You bring that little baby home. It's like, where's the manual? I don't know what I'm doing. I'm a new parent, and how to be a healthcare consumer, right? And
Mhm.
in fact, whether it's a rare or a common condition, you have to learn how to be a patient in a way, or a healthcare consumer. And it always sort of amazes me that there isn't more guidance and education around just how to do that. As a
Mhm.
physician, I have been a patient, and it amazes me how I'll get home and I'll think, now, when is my follow-up, and what did they say exactly about my risk of that? And I'm thinking, I'm a doctor, and how does this suddenly become difficult to put together when I've got all this
Yeah.
expertise? And when
Yeah.
you're a patient, you're trying to experience the knowledge or the information, and then you're also trying to operationalize it and remember your meds and this and that. So I think, you had said, Emmett, something like, just make sure you put your appointment in your phone when you're making it. These sort of organizational tips, and trying to remember everything that we're being told is a big part of effectively moving through the healthcare system. But nobody really teaches us that, right?
Yeah, I think it's a really good point. One of my favorite studies actually pointed out that transition readiness scores amongst all teenagers, including those without chronic care conditions, are really terrible. Like, teenagers in general are not ready to access the adult system. It's just that it's more important for teenagers with chronic conditions to learn those skills earlier, right? Regular healthcare access for people who don't have a pre-existing condition is just not as critical if they're not expecting to access the system with any kind of regularity or with any sort of urgency. But it's important, if you have a pre-existing condition, to figure those skills out sort of earlier and more completely in order to kind of make that transition and figure out how to drive your own healthcare.
Is it possible for the kids who are transitioning to stay with their pediatric doctors beyond 18? Because I think your slide said 18 to 21. So, I mean, why are the doctors in a rush to get them gone right at 18 if there's the option of having that care, especially for rare kids, up to 21?
I can take a stab at that, although I'm sure Leanne, as a pediatrician, might want to add to that as well. I think that so that's American. First of all, that got transition slide that's 18 to 21 is American. And I think that part of what they're talking about with that 18 to 21 is that the transfer has happened, but up to 21, we're still making sure that that attachment to the adult provider has sort of stuck and held. So that's, I think, part of the answer to that question. The other part is that there are different sort of policies and regulations in different care settings about when that in general is kind of supposed to take place. So sort of licensing requirements for pediatricians in general. The licensing for the actual provider, the pediatric provider, is perhaps not as strict as like 18 must go, but that is pretty clearly the case for children's hospitals, which is usually where these multidisciplinary clinics are held. And so they're pretty strict about 18. We're no longer providing service in our children's hospital. And so that becomes a pretty clear cutoff time. Now, that doesn't mean that there aren't patients who are 19 who sometimes pop in to see their pediatrician. That does still happen from time to time, and it might especially happen if there's not yet someone who they've become attached to. But ultimately, it doesn't matter if it's 18 or 21. They've got to make the change at some point, the way that our system is set up. Is it a year later or a year earlier? It probably doesn't make a big difference unless there's some reason to think you'll all of a sudden have access to someone who'd be more ready to take you on as a patient when you're 21, for example.
I just think that not all the kids mature at the same age.
Very true. Very good point. Yes. That's, I think, an evolving area of conversation in the transition literature. But our healthcare regulatory systems kind of ignore that point, to be honest, and don't give us that flexibility.
Okay, thank you.
I don't know if Leanne, you would say something different about that as a pediatric provider.
I mean, everything you said resonates with me, that it is, a hospital policy that we need to transition by 18. Now, I am guilty of holding on to patients longer for all kinds of reasons. And I can write a letter to my hospital and get special permission to hold on to somebody. And I try to find lots of reasons to do that. Some of the reasons, because I find it hard to let go. I really enjoy my patients. And I certainly don't like to transition anybody who has something active going on. If there's something I'm in the process of working out, figuring out with the patient in terms of diagnosis or new therapy, I like to get everything settled down before I hand that off. Some patients are just not as developmentally ready, as you mentioned as well. Sometimes it takes a little bit longer to find the appropriate care provider because the patient is announced, well, I'm now going off to university and stayed elsewhere. And so I'm sort of scrambling to find the best, partnership for them in another city where that maybe wasn't anticipated. Sometimes the therapy I'm giving them is so specialized and it's not available on the adult side. So I have to help the adult provider get together the same highly specialized therapy before I can pass the baton. I mean, that said, the majority I do transition at 18, but I do write these letters from time to time and try to stretch it a little bit longer and find that 18 to 21 is sometimes needed for certain patients, for sure. There is some conversation that in rare disease, maybe it should be a little bit later because of the complexity of what we're handing off. So that is something that's being socialized a little bit, but the hospital policies are still pretty much the same. Ted?
Yeah, one of the things sort of this conversation, and you'd mentioned earlier, say some of the shortcomings with respect to education of adult physicians on pediatric disease. And I just, as you look to establish this clinic, and it's a multidisciplinary clinic with adult providers and endocrinology and nephrology and other areas, and obviously use part of a physiatry program. How do you see the role of a clinic like this in terms of education of residents, and what sort of steps can we take to better prepare our residents as they enter the workforce to better facilitate child to adult transition?
That's such a good question. Rachel, do you want to pop in there? I feel like I'm the chatty one out of the two of us, but.
Yeah, I mean, I think just giving them the opportunity to have clinical exposures to pediatric disease, both at least in our program, they do have a pediatric rotation, but also working with Caitlin and I and others involved in transition, I think is the main thing. So just getting those clinical exposures, and we talk with our residents about transition as well, but I don't know, Caitlin, any other thoughts on that? I think it's mostly just clinical exposure to the adult manifestations of childhood condition.
Yeah, I think it's a hard question to answer. Certainly, medical school might at first blush seem like a really good time to introduce stuff. The problem is just time, right? Like they don't have enough time to learn everything about everything. And so rare disease kind of gets sacrificed in the name of making sure everybody understands what a heart attack is. And that's probably fair. And we want to make sure that the majority of people know how to take care of that as medical providers, and that we'll get sort of into the weeds of more rare conditions if they choose to pursue that area. The challenge is that people don't choose to pursue areas that they don't know about. And so I think that the exposure is kind of the name of the game. And so having a program that people can come into and see what it's like, and it kind of demystifies a condition, has a major impact on whether or not people might choose to whether or not they, have the capacity to set something up like that themselves, even if they go and work in a smaller center, but are willing to accept a referral for a patient who has that condition. All of a sudden that kind of opens things up a little bit for people, especially living in different areas. So I think exposure is really key. I don't think there's probably any way to more globally prepare everyone to do these kinds of things, or at least I haven't come across one yet. And I talk about it a lot with a lot of different people, but I think it really is that exposure. You can get people excited about working in different areas once they see that things are less scary than they think that they are, and that it's fun to work in multidisciplinary spaces and with patient groups who are really sort of invested and interested. And so I think that's kind of a key component.
You know, there's an organization called the Canadian Rare Disease Network, the CRDN, and
Mhm.
you might be interested, XLH community, to go on the CRDN website and just see what's coming up there. So this was started in response to the government of Canada's national rare disease drug strategy. And with rare disease therapies comes the need to have rare disease support in general. And one of the things that's come up as part of the CRDN's narrative and mission statement is to educate healthcare providers about when to detect rare and how to help manage rare, recognizing that the generalist in the community isn't going to be able to provide all the specialty care, but they can be a partner in that care and should learn how to identify rare whenever they can. You know, I've heard many XLH patients say to me, you know, my hearing loss, my physician says it has nothing to do with my XLH. And that's a really good example of a phenomenon where, well, actually it is linked to the XLH and it can start in childhood. And, you know, we want to have people amplified earlier rather than late, and knowing that it's related to the condition helps to get the services that are required. So I feel like we have a lot of education to do around rare disease in general, and exactly when to introduce that into the curriculum, as Caitlin said, is really tricky. But I think it's something that we're going to be hearing more and more about, and thinking through strategies to sensitize young doctors to know when the zebra goes by them among the horses, and be able to pick out the rare conditions, so patients aren't waiting for years and years to be diagnosed, or not having their comorbidities missed because someone doesn't know that they're linked to their underlying condition.
I think to that point too, it's also important to demystify rare disease to the point that not even just like it would be fantastic if generalists were able to identify rare conditions for diagnostic purposes and also to kind of link those comorbidities. We also don't want generalists to be kind of scared of being involved in the care of people with rare disease for their generalist care needs. Like people who have XLH, you know, will still have strep throat, or will still, you know, need colonoscopy screenings. Like you still need to have primary care providers outside the specialty clinic. And, you know, we have a primary care provider shortage here in Canada, and it's hard to get one. And it's especially hard to get one if doctors are a little bit scared to pick up a patient who has a condition that they don't know what it is or what it means or any of that stuff. So I think it's important to demystify for that reason as well. And also to try to make sure people are linked up with experts so that their generalists don't feel like they have to be the expert.
Yeah, those are good points. I think I'd like to start to close the call, and we can just maybe go back to the speakers and just see what their reflections are. And then if anybody else has any wrap-up comments, we'd like to invite those. So Sherry, can I start with you and just see if you have any summary statements for this evening?
Just this was amazing, very educational as always, and I am really looking forward to seeing what develops with the two doctors in the London area, because I know that this is something that our community is really looking forward to, a clinic where adults can be, where children are, you know, transitioned. That is what we need. So looking forward to seeing how that evolves.
Sherry and Alice?
I agree with Mom, and I found it quite interesting. I was taking notes during the presentation, and I think it would be a great thing to have.
Great. And I think, Alice, you know, your experience and what you've learned can be really powerful for your community in terms of sharing what you have experienced and what you're thinking about as a result of that experience. So thanks for bringing that forward today.
Thank you for having me.
And Susan?
It excites me that you're trying to make an adult community. So thank you. I learned a lot.
Thank you.
Yeah.
And Emmett?
Yeah, I'm just excited that these types of conversations are happening and happening fairly frequently. I think they're important to continue having and to be able to help spread more information for everybody.
That's great. And maybe community, we can think about an XLH toolkit, even just starting with a simple checklist of things for the older pediatric individual transitioning to adult care. So we'd be happy to work with you and Dr. Kilikarsla and Serdar, who's helped organize this evening, and the team, I'm sure, would be willing to work with you to think about that further. Rachel, what are your thoughts based on what you heard this evening?
I found it really educational just to hear what the transition process has been like for your community. Some of the problems. I think it's, you know, it's one thing to read the literature, it's another thing to hear kind of firsthand experiences. So yeah, I really appreciated getting that perspective on it. And yeah, learning more about sort of your community in general.
Thank you, Rachel. One of the reasons I love these webinars is because I always learn so much. And it's interesting to sit with the patient one-on-one and learn from the individual. And then it's also very informative to hear the collective voice. And I think these webinars really help us do that as healthcare professionals, to learn from the community. So thanks for drawing attention to that. Caitlin?
I don't think I have too much more to add. I echo the comments that have already been made. I think it was just really great to I appreciate the invitation. It was great to pop on here and see a lot of different faces and talk about issues that I've known about, perhaps more so in other populations, and learn about how we can apply some of that learning in this population as well.
Thank you. And, you know, we appreciate the enthusiasm and the expertise that you're going to bring to this area, right? As a physiatrist and MSK, pain, mobility, movement expert, I think that we have a lot to learn from you and your perspective as a physiatrist. So we're looking forward to that. And Ted.
Oh, and I'd like to thank everyone for sharing their insights tonight. And, you know, I think we all hopefully walk away tonight learning something new. And I certainly did. And definitely want to thank Leanne and Caitlin and Rachel for putting the time and effort into to setting up resources here in London to help people. So it's I'm really excited to see what shape the clinic takes. And from my standpoint, I'm very happy to help in any way I can, and really think it'll work to improve the care for people as they transition to adulthood.
Ted, we always appreciate your support. You were actually the one who introduced me to Caitlin and Rachel, so I have to thank you for building that bridge, and, you know, really grateful for that, and to see where it takes us. Any other comments from the community this evening before we sign off and do the virtual catch up over coffee? Okay. Well, thank you again. And I'd just like to also acknowledge Dr. Nazrin Khan and Dr. Serdar Kilikarslan, who work with me to build these webinars. Dr. Khan, some of you will know from her leadership in clinical trials, including individuals with XLH, and Dr. Kilikarslan and Dr. Khan are both part of my rare bone disease patient advocacy group. And Serdar has helped put this evening together, and I'm grateful for that administrative leadership. So thank you both, Nazrin and Serdar, and for coming tonight.